We have to. I don't know. I may have to break the same news to this group that I did. Oh, you're terrible. You can't. You're not allowed. Or Brooke. Yeah, I understand that. There is a because we have so much to cover left. I may have to give this exam, this upcoming exam, exam three on Blackboard. So we may have to figure that out. We'll have to. I'm going to see what I'm going to have an idea of the logistics. We'll address it either Wednesday or Friday, as I think about it. Okay. That's the best. The final, I don't have a choice with the final. The final, we were going to do it on site here, just like a regular exam. But I've got to get. We've got a lot to cover. We've got respiratory, digestive, urinary, and repro. It's a fair amount of chapters. That's more. It's easily a chapter a week for the next week. That's why I'd rather not have a lecture period utilized for an exam, but try to figure out a window of time. Maybe on that day we can figure it out. We'll go from there. Remember, my ears are clogged again. It's allergy season. It's every day. So that's all the news fit to print. Back to work. Good. Glad to hear it. So today, this is mostly about antibodies and concluding this chapter. Everybody, so we're ready. This just basically shows you effectively what it is. The antibodies are going to be these Y-shaped kind of. Some people say T, some people say Y. This is what they look like, and and they're tailored to, again, what we call the determinant or the epitope. And it's effectively, they're designed to bind, if that's the receptor, they are designed to bind to that particular antigen, and they create something that's sort of a mate to it, biochemically speaking, would be the way to describe it. As you can see, and they have the remarkable capability of binding more than one. So we'll take a little bit of a look at the antibodies, somewhat structurally, so you can get an idea what they're composed of. So they are circulating rather substantial amounts of proteins. They're circulating. We produce vastly large amounts of them when we produce antibodies in a very, very short, relatively short period of time. So this is a nice little summary of these kinds of things. Steps in antibody antigens bearing agents enter the tissue. The B cell encounters it. Okay, typically with the help or the assistance, better rather use the word twice, of a helper T cell, it's activated and it clones. And I said the effector cells are called plasma cells. They are factories that make antibodies. You don't have to know about the structure or anything else. The plasma cells make and give off, secrete very, very molecular structures similar to the activated, which you just saw before previously, this sort of activated B cell, that kind of protrusion that effectively becomes the antibody. This is different. Okay. So, and this is, again, an antigen presenting cell can work through the same thing. And again, use a slightly different way of doing it by way of a T cell. Okay, effectively it'll work through the helper T cell. Will then, and this activated helper T cell will release chemicals. It'll basically activate a B cell, and really the rest kind of comes from that. Again, so there's a couple of different mechanisms. That's not what matters. What matters is that they're having a couple of mechanisms, either directly by encountering that particular, like a virus or a bacteria, or using an intermediary like a helper T cell. The end result is the same. Effectively, we get antibodies. The antibodies, again, are for things that are either, they could be sitting on top of the cell, they could be in the plasma, they could be in the tissue fluid, they could be anywhere. They could be in the lining of your throat, okay, trapped, relatively speaking, in saliva or mucus or whatever substances it might be. So there's a lot of different places. As long as they're not inside the cell and altering the cell's markers in such a way to have a cell that's no longer identifiable, we're going to make the antibodies to address them. So antibodies, they are, and we talk about the gamma globulin, or we looked at blood. globulins. There's beta globulins and gamma globulins. Beta globulins are carrying molecules. They transport fatty substances, particularly when we start talking about fatty acids and fats that are going to be used elsewhere in the body, lipoproteins. They're part of the proteins that transport. Gamma are also known as immunoglobulins. Back in the day, we weren't able to make individual antibodies. The immunoglobulins were something we would give something we extract large amounts of this gamma globulin fraction from suitable donors and inject that as an alternative treatment for something like hepatitis A before we had a vaccine for it. The treatment was gamma globulin, a big whopping dose of sort of these generic globulins. They look like a letter Y. They're composed of 4 peptide chains. I'll show you the way it looks like. They're called 2 heavy and 2 light chains. They're identical. The only place where they're not identical is the ends that they form. Okay, so the chains themselves, other than the tip end where they would bind to the antigen that they're being tailor-made for, are the only places where they vary, more or less. There's similarities in their structures, and there's some differences in there. So the unique site is called the variable region. I'm sure you're going to show you it here, and I'll come back to it. The variable region in which the antibody binds to an antigen in the antigen binding site. All the other part is constant. There are 5 major types. Okay. Then you need to know there's an acronym that I use. You can use it if you. It's hard for me to make an acronym out of GAMD, or EDMAG, but I use MADGE, MADGE. That's what I use. You can use whatever. I don't care how you memorize it, but memorize it because you should be familiar with these. These are the 5 major categories based on that constant region. The IgM, as you can see, the vast majority of these are IgG. Also short for immunoglobulin G. That's the arm that's immobilizing and deactivating bacteria, viruses, toxins, etc. That's their job. They're the active part of this, but more so than anything else. IgA, as you can see, a rather substantial amount, it's about 1/7 of all of these antibodies. They're in your secretions, whether it's a sebaceous gland, a sweat gland, whether it's mucus, whether it's saliva, whether it's any one of the fluids that line the anogenital area. They're there to protect you. They're there all the time. So you'll see that as we look through that, that's a really important part of sort of our innate aspect of our immune system, the IgA, because it's in the secretion. I mean, so again, we're pre-programmed for. They're somewhat generic in the sense that they'll deal with antibodies and viruses. And again, I've said this in my micro class, and if you were there, you heard it. Effectively, it's a numbers game. So we have the larger the numbers of bacteria or viruses or whatever that we're confronted by, sooner or later you're going to run out of things like IgA to trap them and block them, and they're going to colonize and create problems. IgM, okay, it's not just foods and bacteria. When IgM is the fraction that's produced first, they're the largest of these because they actually, and you'll see, they come as something called a pentamer. There's actually 5 of these at one time. I'll show that to you. You should have a diagram of it here. I'll call up another PowerPoint that I'll be able to demonstrate it to you. So what we do, we have the ability to do something called, it's a fancy term, it's called immunoglobulin, these guys, electrophoresis. Electrophoresis, maybe you did it when you were in high school. You're able to use electrical current and you separate things. It's kind of the way we do like DNA typing. Okay, it's like creating a barcode, a biological barcode. And we do that by applying electrical current and have something move through gels. So we can identify these by seeing, but we can do this by way of a blood test and see which one of these. So if you have a preponderance of IgM, it means you're typically in the early stages of fighting the infection. If you have a preponderance of IgG, you're in the later stages. For instance, now let's say if you're monitoring and let's say the patient is not doing particularly well, and you see they still have a preponderance of IgM, that tells you that your body's immune system is having some problems coping for it because it's still using an early response for something that should be well into the later response period. So those are just some of the things. And it's not. This is not something I'm going to ask you to recall on an exam. I think it's just something that you should be familiar with regard to these things. IgD is for years we really didn't know what it was. It probably is a marker that things can latch onto on B cells. That's the current theory. And IgE is really important. IgE, if you remember going back to the blood unit, and we talked about the white blood cells, remember basophils, when they leave the bloodstream, they typically become what are called mast cells. That is the arm of our allergic system. IgE typically inserts itself into one of these. Remember, they have filled with granules. The granules contain histamine, and that's what, remember the inflammatory response. Histamine granules are released from a variety of white blood cells. They dilate blood vessels, swelling, redness, that whole deal, the cardinal signs of inflammation. If you're it's like me having an allergic response now, which I've been having for the last couple of weeks, nose is stuffy, spraying it, taking Zyrtec helps a little bit. Basically, IgE, those allergens are triggering mast cells that have IgE, releasing those chemicals, and it's causing swelling and a greater amount of mucus production, et cetera, et cetera. The big problem is when they're concentrated in your lungs, because they're the linchpin that creates something called anaphylactic shock. So there's not, I mean, all of these are important. So here's what it looks like. The darker blue regions here and here are the constant regions. You have the heavy chain and the light chain. These are constant regions. The light chain you can see is quite a bit smaller, but this is the part that's variable. This area is altered and made specifically to attach itself to whatever it's, whatever it is. If it's shaped like a eraser on a pencil, it attaches to that. It's like a tip of a pencil, it attaches to that. That's the unique thing about this. Proteins get disulfide bonds or bonds, not that you have to know this, give structural stability. Disulfide bonds typically we see in proteins that have a lot of structural sturdiness that are there. And here they are. IgG defends against bacteria, viruses. It activates something called complement. Complement is, and we talked about it a little bit before, I think. Complement is one of these substances that helps the inflammatory response, helps phagocytosis, plays an important role even in utilizing the methods that we destroy invaders. So again, the IgA is in the secretions. The IgM is in the plasma. Reacts with the antigens on some red blood cell membranes following mismatched transfusions and activates complements. Why IgM is interesting because it's, I'll show it to you on a separate PowerPoint. And maybe we don't do it in the lab where I do blood with my advanced phys. We actually, they lance their fingers if they want to, and they do a blood test to see it. Maybe you did this in high school, where you look for your blood type. Some of you probably did that. Yes? Yeah, okay. IgM is the one that's in the plasma because what happens to the blood is speckles. Little speckles are called agglutination. What that does is it latches onto multiple red cells because it actually has 10 sites. That's what I mean by being a pentamer. Okay? And again, the Ig is here. So let's see if they have, I'm going to see if they have the pictures. Oh, that's very upsetting. They don't have the pictures. All right, hold on. Far be it for me not to give you an illustration. So, I have to get used to this PowerPoint vis-a-vis some of the things it has or may not have. But I can rapidly give it to you. We're right here or in that neck of the woods. So that's kind of a schematic of what an antibody would look like. Big old lump of protein. There's some good news and bad news with this. Okay, what you're going to see that there are diseases Okay, and diabetes is one of them. Why we think diabetes has what's called an autoimmune component, because it forms clumps of these proteins that get in your kidney and damage it. So that's was one of the tells for type 1 diabetes. So here are the classes. The largest is the, because it's five of them, you'll see it, is the IgM. It's the first one that's released. And what it does, just like if you tested your blood and you put some of the anti-B and anti-A little speckles form, those speckles were red blood cells being latched onto simultaneously. Okay. IgA is typically a dimer. There's two of them. So here's what it meant. There's 1, 2, 3, 4, 5, all latched together. Here's the dimer of IgA. The other ones, D, G, and E, as you can see, are all monomers. Really, the significant reason I'm pointing it out to you is more because of this potent agglutinating ability that's here. And then as we go through the same thing, and now we're in that same area we were talking about before. So we back up. I'll go to the other PowerPoint, just having that handy, and I'll have it handy for the next, because they all, it's basically the same information, as you can see. So how do antibodies work? These are the three major areas, and the fourth one, it means it activates complements, as you can see here. So how does it work? Agglutination, creating clumps. Why? Because these things are tiny, even to the realm of cells. Even so, a macrophage is going to gobble. Remember, antibodies don't destroy. What they do is basically immobilize, tag, neutralize, precipitate. They make things more visible, if you will, on a microscopic basis to white blood cells, macrophages, to come along and gobble them up. It's like the bakery industry. We eat our mistakes. Works for me. It's okay. So many croissants, so little time. It's all right. Going back getting my car fixed. Oakmont Bakery. Here we go again. So they agglutinate, they precipitate. If they take them out of solution, white blood cells can gobble them up. Agglutinate, same deal. Neutralization, a lot. How do bacteria usually do their damage? They make toxins. And so toxins are just that. They're toxic. So you have to neutralize them. When you give, and I talk about this in my micro class. When somebody has, if you're not tetanus current and you get a tetanus prone wound, tetanus occurs, it produces a toxin that goes through your nervous system and can kill you very, very quickly. Comparatively speaking, you have no time for a tetanus shot to work. And because of that, okay, you have to give somebody a dose of the antitoxin. So basically, a whole unit of these antibodies, we just call them an antitoxin, even though they really are nothing more than antibodies. If someone is bitten by a venomous snake, they give them what's called a polyvalent, which means many different types of polyvalent antivenom. It's really a megadose of different antibodies that will attack any of the likely snake venoms in the area. We don't see that so much here unless they're in an area where there's a predominant amount of snakes. A close friend of mine was the lead pharmacist for a big hospital system. He was traveling around like 6 or 8 hospitals. They were based outside the San Antonio area. I mean, I opened up by his bar. He had a refrigerator. My wife and I at the time, our kids were visiting with him. We were very close friends. Opened up the thing, and there was like a dozen vials of snake antivenom. Oh my God, what's going on here, Ed? And he goes, oh, no. He says, I have to deliver those all the time. So, and you have to keep them refrigerated. So I always have a supply here in my fridge. And then if I have to go to one of my hospitals, they just let me know, we need 2 more vials or 3 more vials. Figured we were sleeping there. I was getting a little concerned. In the lovely city of New Braunfels, Texas. No Texas fans here. San Antonio, the Riverwalk. Magnolia Pancake House. Best diners, drive-ins, and dives, as good a breakfast as there's. Oh, hash you could cry for. Cry for. Complement. Complement is the other method. Complement is it's again, these are proteins in your bloodstream that are activated like the clotting proteins in a cascade. One gets another one, gets another one, gets another one. Okay? And it occurs more effective against antigens than a direct attack. So certain types of antibodies generate this, and what they do, they activate it, they agglutinate. They create that opsonization that facilitates phagocytosis. They are ones that attract other white blood cells to the scene. We call that chemotaxis. They can directly damage membranes of a variety of pathogens. They can neutralize them, change the structure of viruses so they are harmless. It's an extraordinarily effective system. It's one of the ones that medical students study very significantly. The whole idea of a whole subset discipline for physicians is called allergy and immunology. That's it. When we talk about a discipline, they have a board certification for it. And so these are allergists and immunologists work hand in, they work effectively, they're the same certification. It's a very, very complicated area. So local changes of inflammation spread the infection. So IgE antibodies on mast cells bind to antigens. Antigens produce that histamine. Okay, causes edema and vasodilation. So you're trying to create local changes that will stop it from spreading. We talked about that a little bit before, about how that where it increases the amount of fluid to the area, more white blood cells, more healing factors, clotting factors that are able to, let's say, wall it off would be the way I would describe it. And they're just showing you some of the things that this complex of antigens and antibodies can have. They can agglutinate, in other words, they can bond to multiple ones at the same time. They can precipitate it, same method, neutralize it if it's a toxin, basically block all of its active sites where it could attach to something, activate complement, and all of the things. Opsonization, which works on that constant region, facilitates phagocytosis, in pro-inflammatory agents, breaking apart cells directly, all sorts of good things. It's a very powerful, immensely powerful system. That's the good news. The bad news, when it gets out of hand and you have an overly exuberant response or an inappropriate response, now we're going to enter the realm of what are called autoimmune phenomena. When the immune system works wrong, it causes an immense amount of problems. It's an extraordinarily complicated, very interesting topic, very complicated. And they're just summarizing all the things, the way that it works here. So, different things. How we're using these technologically. Immunotherapy makes use of immune system components to fight disease. Okay, so basically the humoral immune response by antibodies and the cellular immune response by cytokines. Unfortunately, I have a lot of information about this because I was treated immunologically. I was talking about this earlier today. Okay, I had immunotherapy. I discovered my bladder cancer in 2015, 2016. So, less than 10 years ago. So they started me on immunotherapy. Basically giving me, interestingly enough, a bacteria. And that bacteria is something that is absorbed by cells and triggers them to respond immunologically. So it was trying to trigger the lining cells in my bladder to be able and provoke the immunological response and begin and effectively create an immunological response directly to them. Very, very effective. The frame for all of this is, for years, how do we treat cancer? We basically cut it out and we bombarded people with radiation or nasty chemicals. It's not very scientific. It was a treatment. You can only use what you have available. But you were trying to selectively, you're basically giving them a chemical that's going to kill them in the hopes that you're going to kill the cancer cells before you kill the person, or you're going to subject them to radiation and hope you kill the cancer cells before they get radiation poisoning. That's a game that's fraught scientific albeit, and at the same time, you're typically cutting out the stuff. So immunotherapy is a very much of a progressive field that we use. So a lot of things sort of stem from this. It just so happened that immunotherapy triggered an irregular response in my immune system, and I ended up developing, or it ended up causing the appearance of, I probably was predisposed to it, had the genetic markers for me to have an immunological flare. I developed an immunological arthritis, and then I had to start taking medicine to suppress that flare. Go figure. So, like I said, I was on the wrong end of the immune system, first trying to stimulate it, causing a problem, and then having problems with the medicines they were used to try to curtail it, which is why I stopped taking all of those things. Now, as I get to my golden years, don't start. Good. Yeah, yeah, I saw it. You gave me the look. Okay. Monoclonal antibodies. Okay, these have been around for a while. They were an excellent treatment during COVID. That were not pushed because they were pushing the vaccine very hard. So they fused them with a cancerous cell to produce a typical type of antibody consistently. So they're used in a lot of different things that are there. So you can see, I guess they're used in research in agriculture, pregnancy testing, detecting certain kinds of cancers, early therapy for mild to moderate SARS-CoV-2, that's COVID-19. So that was something that was given. My son got that there's a clinic in West Mifflin. So as long as you tested positive for COVID, it was about a $2,000 dose that was paid for as long as you had a positive COVID test, because insurance typically didn't pay for it. And yeah, it was. I mean, it's so powerful that where he got. I mean, he had driven himself, which I was a little surprised. But they basically held him there for 2 or 3 hours till he goes, "Dad, I could hardly focus on anything, much less drive a car." You know, he's a professional driver, so he knows what he's doing. Cytokines. Okay, we can make these things just like monoclonal antibodies. So we utilize these different agents like interleukin 2. These are chemicals that are produced by your immune system that are very, very powerful, these interleukins. You know, I was taking a variation of one of those. I was taking a medicine called Cosentyx, which basically blocked a pro-inflammatory interleukin called interleukin 17. Okay, and I was taking another one called Humira, because the Cosentyx was very hard to tolerate, and Humira blocks something called tumor necrosis factor, which again is something that's a very aggressive aspect of our inflammatory system, and you're trying to block it. But they're both fraught with dangers that are there. Okay, and there's these chimeric antigen receptor T cells I'm not familiar with, so I know they're working with modified T cells. In the early days, this was what some of the early arm, they would take out T cells, isolate them in the laboratory, modify them, basically cause them to grow in large numbers and re-inject them. That was one of the early treatments for melanoma that was developed years and years ago at the National Institute of Health. Now, the whole idea of understanding is pretty much the theory behind why we use immunizations, why we use vaccines, what we generically call vaccines. Your first encounter with an antigen, okay, B and T cells specific for that antigen become activated, first IgM, then IgG. We don't see antibodies in blood levels that are measurable for 5 to 10 days. That's a long time for someone to be having an infection before our body mounts a response the first time they're challenged by it. Okay, but we know it produces memory B cells. So the second response is different. We respond to another exposure to that extraordinarily rapidly. Okay, we produce high concentration of antibodies in a matter of hours or days, and those memory cells, be they B cells or T cells, and they can remain there for months or years, and they can live for many years. This is the idea why we get immunizations. Why do you get that tetanus shot? Why do you get MMR? You're getting those things because you're going to create, hopefully, what you're doing is you're getting something that has been attenuated. When you attenuate something, you alter it. You change it in such a way that it'll trigger your immune system as though you were having an exposure, and yet you will not get sick or not get so sick that it would cause you significant illness or difficulty or impairment. So that the next time around, that's why a lot of times you get an immunization, maybe you have to take Tylenol for a day. You probably don't want to get it at the same time you have a viral infection because your body's naturally producing certain kinds of interferons. And it's basically the way it works. But we realize that that's the most important thing to do, is because a lot of these things, and I tell this to students all the time, why do we give somebody a tetanus shot for a non-tetanus wound? Something that would never cause them tetanus, because it's for that other time when they're not tetanus, to make sure they're tetanus current, when all of a sudden they're out in the woods hiking, take a fall, have a broken bone that's exposed, a major tetanus, some scenario where they can't get help right away, and tetanus could start early, and by the time they got help, it would be too late. So that's the idea of why we utilize immunizations when they're utilized appropriately. Would be the best way to frame it. And yeah, you're getting some of my spin, but that's the price you pay for being stuck with me a couple of times a week. Even I don't like it. I keep wondering why my wife keeps giving me a list. Oh, you better go to the store and get this, go that. I need this. Yeah, I'm joking. But here, the primary response, and you notice that number 10 where it really starts to get significant. So how long do you get a prescription for antibiotics for? Typically 10 days. That's why it's so important. I emphasize this point when the antibiotics unit we're doing in my micro section, but I'll give it to you folks who are not there. That's why it's so important for you to tell your patients, take the whole darn thing. There's a lot of people, I felt great after 5 days. I figured I'd save it for the next time. Little Johnny gets their ear infection. I don't have to go to the doctor. All that does is make resistance. It's not a good thing. There's a reason that we do it for 10 days. This is the reason. We know it takes that long. The only bacteria that are being destroyed are the ones that are relatively easy to kill. We want to get rid of the hard ones too. But the second time, we don't have to worry about that, because you ramp up to a very, very vigorous response in a relatively short period of time. It's a wonderful graphic image you see in every single textbook, from the primary to the secondary response. And so and these are 4 important classifications. Okay, when they talk about naturally acquired, and the way that this is called active immunity. Active immunity is permanent or relatively permanent. Long-term might be a better word. Obtained by antigen contact, the immune response is evoked, and memory B cells are produced. I, as a kid, got the measles. I, as a kid, got the chicken pox. I, as a kid, got the German measles. Right? We didn't have immunizations for those. There was no MMR. There was no chickenpox immunization. Okay. I had those. That is active immunity. Call that naturally acquired, obtained by a natural process, such as getting and recovering from the disease, or something that you might have acquired that immunity, mother to child. Artificially acquired would be an immunization. Passive immunity, by definition, is temporary. So passive immunity would be at the birth process, where your mom's antibodies are protecting you for about 6 months until your immune system starts to ramp up, where it gains a certain degree of competency. So much so, and some would argue perhaps too early for us to start utilizing immunizations. I don't know enough about it. I know a lot of people are against it. A lot of people are for it. I keep saying that the reason I think the most important thing is there's no reason we can't make an immunization safe. A lot of the problems are the preservatives that are in them. That's an ongoing debate that you're going to get vigorous debate, either pro or con on either side. So Naturally acquired passive immunity is from your mom. Okay. Artificially acquired is that shot of gamma globulin I was talking about, where we'll give somebody a dose or giving that antitoxin to somebody who's not tetanus current and they just had a terrible industrial accident and they have a nasty wound, deep wound, irregular. And when that happens, that's called a tetanus prone wound. You don't have the luxury of waiting. It's going to take, 2, 3 weeks for that tetanus shot to work. So we better at this point in time give them some of the antibodies because they're probably going to last for about 6 months. It's the idea. This is really important stuff. If you're going to nursing, people are going to ask, why do I need a tetanus shot? And believe me, there's an intention to give it. I knew exactly. Let me see. We just got the dog. It was the summer of 21. We had the dog for a month or so. The dog knocks over something. I cut my foot. I knew I had a tetanus shot in 2019. I went to the emergency room. I'd like to give you a tetanus shot. I said, that's nice, but I had one in 2019. Well, we don't have a record of it. I know because it's in my doctor's office, and this was at a UPMC. It was an AHN facility. So I said, respectfully, I will refuse because I don't need to get another one. I am confident what the last one was. It's a good thing for you to write down for you and your family. So they have a note of that. And then the next thing I did was later that day, I called the doctor's office. I said, by the way, when was that tetanus shot? Oh, that was in whatever of 2019. Okay, gotcha. They believe me, we don't like you refusing it. Well, I don't like getting an extra one if I don't need it. So I'm the one who's paying for it. Note down, dickhead of patient refuses tetanus shot. Oops. Something I said? Moving on. So here they are. Nice table to produce this. Breast milk also produces. They're making a breast milk ice cream. I saw that. Oh, that doesn't sound particularly desirable. That's a flavor I'd avoid. That's not chocolate mousse tracks, but what is? Or Jamocha almond fudge. Other things, allergies. Okay, hypersensitivities. Hypersensitivity is where we discuss allergies. There's varying degrees. So an exaggerated immune response to what would normally be a non-harmful antigen. That's really what a hypersensitivity is. And typically it's the wrong term, you have to be pre-sensitized. Meaning you don't get it the first time around. And I'm going to tell you this again. If I didn't tell you, I will, because they got it in when I talked to my micro class. I had a patient who was are you ready, in her 70s, who was a nurse. Okay. And I treated a diabetic lady. I treated her for an infection in her foot, gave her a prescription for amoxicillin. The next time I saw her, she had just coming back from being in the hospital. And I said, and she goes, I was allergic to that. My foot blew up. I said, really? And I knew her doctor. And I said, but I asked you, I said, I asked if you were allergic to penicillin. She goes, I never was. I've taken penicillin many times. So why all of a sudden, at nearly 75 years old, retired nurse already, well, all of a sudden she become allergic? And the answer is nobody, because you can't predict the darn immune system. Don't work that way. So allergies can happen anytime. So almost anybody can be affected. Can affect only people with an inherent ability to have this kind of response. So you have to have a competent enough immune system to have this occur to you. And effectively, we all do. If not, there's some immunodeficiency, and that's more problematic than a hyperallergy because your immune system is your way of guarding against. This is what I'm talking about. A typical allergy is called a type 1, and it means immediate reaction. Person produces IgE antibodies, IgE that are basically stuck in against a particular allergen, and quickly after contact those mast cells, those basophils, are filled. The principal granule they have is histamine, and oh my God, they'll dilate blood vessels. There'll be swelling. There can be a rash. There can be hives. You can be coughing or sneezing. You could have GI disturbances, and the worst possible one, anaphylactic shock. Because what that will do, it will cause bronchospasm of the tiny bronchioles in your respiratory system. The next unit we're going to do after this is respiratory. Anatomically, you will see. I know you had anatomy. You were blowing up the sheep plug, okay, to see how that worked, okay. This isn't something that's in those where you were blowing up. You were getting inflation, but understand that micro. These are microscopic vascular structures that clamp down. So you can't open that with a tracheotomy or anything like that. That's why people carry an EpiPen, just for that reason. Because that's a potent bronchodilator that works very, very, very effectively. So all of these are part of it. So it could be an asthmatic attack, which is a certainly a severe form, but probably not an immediately life-threatening form. But it's something that needs to be addressed very, very rapidly. So when someone asks you if you're going to be in a clinical field, if they say they're allergic to something, the next thing you have to say is what happens. If they tell you they get a stomach ache, it's probably more of a side effect. They tell you you get a headache. I'm not dismissing the gastric disturbances, but they in and of themselves are not necessarily proof positive that's an allergic attack. If they tell you I get hives, I can hardly breathe, I swell up like a balloon, I get a horrible rash, that's something I would be very, very cautious about using any medicine in that category. Discussion we had in antibiotics vis-a-vis and micro vis-a-vis penicillin. Type 2, antigen binds to specific cells, causing phagocytosis and complement. This is the classic transfusion reaction. These are really nasty, okay? Because you're basically what happens, you remember we have my type A mixing maybe with your type B. Because not only do I have A have antigens to A, but we have antibodies to B. B has antigens for B and antibodies to A. The two of them mix together, they attack each other vigorously and rapidly. They form antigen antibody complexes that clog the kidneys, big trouble. Because kidneys to shut down, that can be immediately life-threatening. It has to be addressed. So that's a very significant reaction, these transfusion type 2 reactions. This is another one. Antigen antibody complexes are not limited to transfusion reactions clogging the kidney. They deposit in certain tissues, okay, and they damage those tissues because of these deposits. These complexes cannot be cleared by root. They can't be phagocytized. It's not in the transfusion reaction. You get so many, and they tend to happen in the kidney. They tend to accumulate in the kidney, and they can't be cleared. Particularly the hemoglobin aspect that's in there, because it involves red blood cells. This is different. When I told you about diabetes, this is an example. Rheumatoid arthritis. This is a classic systemic lupus erythematosus. These are major immunological diseases that are highlighted by these wads of protein, they're called antigen antibody complexes, occurring in organs. And over time, they're going to damage those organs significantly to the point where they, long term, can be fatal that are there. And then the type 4 or delayed reaction can affect anybody. Repeated exposure, the allergen activates T cells in the skin, and it takes 48 hours or so. Why is this significant? This is delayed reaction hypersensitivity, is something we see and is the basis for the tuberculosis test. And believe me, all of you are going to have to be, if you're going to be in a clinical setting, any of you, you're going to have this test done every year, but mostly because there's tuberculosis around. Tuberculosis is one of those interesting bacteria that's airborne, stays in the room, stays suspended. More contact you have, potentially you can develop effectively a kind of active tuberculosis exposure. So you're always tested for that repetitively. How long does it tell you? It, they don't give you the tuberculosis. They give you what's called a purified protein derivative, a lookalike protein. And what happens, typically giving it to you here, what do they tell you? You can't tell right away. Oh, I called them up that day. My arm blew up. That's an allergic reaction to that protein. 48 to 72 hours. It has to be a specific size. It has to occur within a specific timeline to be positive. It's one of the reasons we don't use, first of all, there's not really an effective immunization for tuberculosis. And two, if you have the immunization, what happens, you'll always have a positive tuberculin test. It sort of renders it useless. That's the kind of thing that happens with regard to that. So at that delay, the other thing that acts like a delayed reaction like that, contact dermatitis. Poison ivy acts like that. It takes a good 48 hours from the exposure to rear its ugly head. So let's stop it here. I don't think there's a whole lot else to add to this at this point in time, and I'll see everybody on Wednesday.